host, Chris Payne, and I am the editor for MS Focus. Before we get started, I'd like to introduce this year's National MS Education Awareness Month booklet. The theme for 2024 is MS Warriors, Battling Autoimmunity. We wrote this booklet with the aim of providing a deeper awareness of the immune system, benefits of and advances in treatment, and how you can advocate for autoimmune research in your community. If you are currently subscribed to our MS Focus magazines, then be on the lookout to receive your 2024 booklet in the next few weeks. If not, please respond to your registration email for this webinar, and we can add you to our mailing list. I would like to take the opportunity to thank our sponsors, Genentech, Sandoz, Viatris, EMD Serrano, and Sanofi for making this booklet and today's webinar possible. Thank you all for your time and enjoy the webinar. Now I'm delighted to introduce our speaker today, Dr. Ben Thrower, who will be presenting research updates on MS and autoimmunity. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for MS Focus Multiple Sclerosis Foundation, and he enjoys contributing to our quarterly MS Focus magazine. We're pleased to have him join us this afternoon. Dr. Thrower, thank you very much for being with us, and now I'll turn it over to you.
Great. Thank you, Chris, and thank you to everyone at MS Focus. We appreciate everything that you folks do. Thank you also to our sponsors for making this possible. I'm going to see if I can pull my slides up here. Perfect. So as Chris said, we're going to take a look at sort of some of the updates on epidemiology and immunology and how we think multiple sclerosis works and how that might lead to treatment changes in the future. I wanted to start with who we think gets multiple sclerosis. So traditionally, for many, many years, we said that 400,000 people in the United States had multiple sclerosis and that multiple sclerosis was more common in white people. We know now that there are far more individuals with MS living in the United States, about 1 million people in the US, and it may be more than that. This data is now about 3 years old. And interestingly, for the first time ever, when we look at newly diagnosed individuals, we're seeing an awful lot of Black females who are diagnosed now. That's a subject of quite a bit of discussion and research. Does that represent a true change in the epidemiology, or is it that we're more aware and we're looking for MS across more diverse populations, or is it a combination of both? And I don't know that that's settled yet. I personally do think that the epidemiology is changing some, and that would raise the question of why, and I don't know that we have the answer to that. So where did MS genetically originate from? So traditionally, we have thought that the genes for MS, and there are over 200 genes that contribute to a person's risk of MS, we thought those originated in Western Europe, particularly around the British Isles. And still, when you look at some places in the British Isles, like the Orkney Islands off of Scotland, you see these incredibly high prevalence of MS. If you look at African Americans, we know that the risk of MS in African Americans tends to come from some of those European, what we call HLA types. So the more European genetics a person has, maybe the higher the risk of MS. There's a fascinating study that just came out about 2 months ago that said that the story is really a little more complex than that. That even though the genes we see them in Western Europe, they really came from Central and Eastern Europe. That there's a group of people called the steppe pastoralists and they originally sort of lived in what would now be Russia, and they sort of spread out and started kind of putting genetic influences into Western Europe. And now we can show that the genetics for MS probably originated in that group of individuals, and they migrated to Western Europe about 5,000 years ago. So quite a bit of interesting research in the past few years on Epstein-Barr virus. So when we think about how a person ultimately gets MS, we know that there are genetic factors, but MS is not a strongly hereditary disease. And there are a lot of different ways of looking at that. So if you have MS, what's the likelihood that you can find a family member with MS? Well, it's only about 10% of the time. 90% of the time, a person with MS cannot identify a family member with MS. What is your risk of MS if your mom or dad has MS? It's about 2.5 to 3% chance of having MS. So genes do play a role, but MS is not a strongly hereditary disease. Things like low vitamin D levels, smoking do seem to contribute some. Obesity, especially in teenage girls, confers a little bit of a risk factor. But a really big risk factor seems to be Epstein-Barr virus. So what's going on there? Two interesting studies here recently. 2022, there was a study of 10 million. So wrap your head around that for a second. 10 million active duty military personnel. And so these were active duty military personnel that had medical records collected. And what they did in these individuals is these folks have blood testing done when they enter the military. They're not testing them for Epstein-Barr virus, but the blood was saved. And so these researchers were able to access this blood. And what they looked for is individuals who were negative for Epstein-Barr virus when they entered the military. And at some point during their military career, they picked up Epstein-Barr virus. The challenge in researching Epstein-Barr virus is that it is what we call a ubiquitous virus. Most humans have been exposed to Epstein-Barr virus. If we do Epstein-Barr virus antibody testing in adults, 95% of adults have antibodies to Epstein-Barr virus, meaning we've been exposed at some point. So you can't just say, well, it's that I'm looking for people who have been exposed. It's the timing of the exposure. So with these extensive military records, they were able to look at people who were negative and then became positive and look at what their risk of MS was. What they found is that at the time that people seroconverted, that they picked up their Epstein-Barr virus, they were 32 times more likely to develop MS within those 5 years of conversion. So clearly something's going on there with Epstein-Barr virus. Around that same time, researchers at Stanford were able to identify a protein receptor on the surface of the Epstein-Barr virus and how the human immune system in a genetically primed individual was sort of generating an antibody to that receptor on Epstein-Barr virus, and how that antibody then cross-reacted with an antibody in the central nervous system of humans. So we call this molecular mimicry. The idea is that your immune system gets fooled. It says, well, that's a virus. I'm going to kill that virus whenever I see it in the future. But that virus kind of looks like that myelin protein in my brain or spinal cord. So it starts cross-reacting. So the Stanford researchers really took things quite a bit forwards in our understanding of that. The hope is that maybe this leads to newer treatments in the future. So this is the way we've traditionally thought of MS sort of acting over time. And this is a busy slide, but what it shows here, and hopefully you can see my arrow, the white sort of bars on top, these are relapses and then recovery from relapses. So when the person with MS, with relapsing remitting MS, And I would say primary progressive MS is going to be a different looking graph. Primary progressive MS is just going to be a slow sort of line upwards. So it's the least common form of MS, and it does play by some different rules. But when we look at the majority of people who start with relapsing remitting MS, when you have your first attack, we call that a CIS, a clinically isolated syndrome. So a lot of times this is when people are going to present to the medical community for evaluation. But if you look down here, so these little yellow blips are new lesions on MRI. And so what you see is that when the person has their first attack, there's been stuff going on MRI before that. So every now and then we do pick up these individuals. So, someone, let's say, has a migraine headache or they have a head injury and they get an MRI for that reason. And lo and behold, we see things that look like MS on their MRI, even though they've had no symptoms. We call that a radiographic isolated syndrome, or RIS. And we know that a lot of those individuals will go on and have symptoms in the future. So traditionally with MS, what we see is an attack, the person gets better, they have an attack, maybe they keep a little something, they have an attack, keep a little something more. And then over time, what happens is the relapses are spreading out and getting fewer and fewer, but the person is now accumulating disability. This red line is axonal loss. This might be measured by atrophy in the brain or by black holes on MRI, these little punched out lesions where nerve fibers have been damaged, or by some of the more sensitive, newer things like thalamic volume. But you can see over time, you're losing tissue over time. And then this is the cumulative number of sort of white spots over time is sort of slowly going up. But you see kind of a curious thing here that so disability is getting worse, but you're not accumulating new MRI lesions. And we're going to talk about that sort of phenomenon. So what's driving progression of disability in a person with MS? Well, one thing is just the relapses themselves. So every time there is an attack or a relapse, there's about a 30% chance the person has accumulated a new level of disability. But we know that the relapses don't tell the whole story. In the second bullet here, we do know that disability can progress even when there are no relapses and even when there are no new lesions on MRI. In recent talks for MS Focus, we've covered this before, but I don't think we can talk about it too much because it explains so much of what frustrates people with MS. And I think it really is the next frontier of how we manage MS. So this is a term you're going to see out there, progression without relapses or progression independence of relapse activity. The acronym is PIRA, PIRA. So what does this look like in the exam room? So you're sitting down with your healthcare team, your neurologist, the nurse practitioner, the PA, and they say, you know what, your MRI shows no new lesions, you've not had relapses, and you say, I know, but I'm still getting worse. And so it's progression of symptoms, even when your MRI is stable and even when you're not having relapses. I think it's important for people to know we believe you, we know it happens, and it is an area of a lot of research. So what is driving that progression independent of relapse activity? One thing that we think drives that is a loss of neural reserve. Neural reserve refers to how much can I injure my brain or spinal cord and I get away with it. So as we age, we all lose neural reserve. So as a person with MS is aging, maybe those old MS lesions, they didn't change, your MRI is not changing, maybe they're giving you more issues because your brain and spinal cord just cannot adapt to them as well as it did maybe when you were younger. So in this scenario, again, it's not the MS that's necessarily changing, it's your brain and spinal cord's ability to adapt to those injuries. And so this is again a model that we've covered some in the past, but again I think it's so important. And this the analogy I like using is the lake model. So imagine your old MS lesions are like tree stumps in a lake. And so these are maybe old trees that have been cut down and now they're in the lake still. Some of those tree stumps are above the surface of the lake. You can see them. Some are below the surface of the lake. They're not obvious, but maybe they're just under the surface of the water. So think of these as like lesions on MRI that are not giving you any symptoms, but they're there. You can see them on MRI. The ones that are above the surface of the water are the ones that are giving you symptoms. So neural reserve is like your lake level. So as we age, our lake level drops a little bit. So now, so actually, let me go back here one more time. So now that tree stump that was giving you this much trouble because the lake level has dropped, it's giving you more trouble because the lake level dropped. Maybe a tree stump that was below the surface of the lake that wasn't giving you any trouble at all is now giving you some trouble because the lake level dropped and now it's above the surface of the water. So with this model, we think about current disease modifying therapies. What those are designed to do is prevent new tree stumps in your lake. They don't get rid of old tree stumps and they don't put water back in the lake. So it really speaks to, a need that we have in multiple sclerosis therapy. We certainly want to prevent you from having any tree stumps in your lake, but we'd also like to in the future be able to get rid of them or put water back in your lake. So one of the other things that we think drives this progression independent of relapse activity is called smoldering inflammation. So this is a low level of inflammation that maybe we're not seeing on standard MRI. So you can think of MS as like a big forest fire. And now we come along with your disease modifying therapy and we put the fire out. As far as we can tell, you're not having any new lesions on MRI. You're not having any relapses, but maybe just under the surface, there's some little smoldering embers. So these are some things that we can't necessarily see on standard MRI, but it's just enough of a smolder to give you some slow progression of symptoms. So what do we think might be driving that smoldering inflammation? So one of the other ways that we think of smoldering inflammation is something called compartmentalized inflammation in the brain and spinal cord. So again, if you have a forest fire of inflammation, the inflammation is going on in the bloodstream, in the immune system outside of the brain and spinal cord. And again, with therapy, maybe we put that part of the fire out, but maybe again, these little compartments of local level inflammation in the brain and spinal cord. One of the things that we think may drive this sort of smoldering or compartmentalized inflammation are cells called microglial cells. Microglial cells are part of the immune system. They're in the brain and spinal cord, and normally they do good things. They're on cleanup duty in your brain and spinal cord. They clean up microbes, they clean up dead cells, they clean up protein material that shouldn't be there. But evidence is starting to suggest that sometimes they go awry and they can do bad things. They can cause this low level smoldering inflammation. And because they're sort of compartmentalized in the brain and spinal cord, maybe it's hard for our existing disease modifying therapies to really get in and put that level of fire out. The other thing that we think may drive some of this inflammation in the central nervous system itself are B cell follicles. And we'll come back to this thought in just a second. So this is the way we think that microglial cells might sort of cause some smoldering inflammation. So, and this is a little bit busy, but so this would be an area of inflammation in the brain that's just starting to crank up. So the blood-brain barrier is open here. The door to the brain and spinal cord is open. So these microglial cells come in and they're setting up shop. Now this is active inflammation. So you've got T cells and B cells, and they're all of the things they do causing active inflammation. So as the big fire is put out, so now you've got these microglial cells that are sort of set up shop. The door to the brain is closed, the blood-brain barrier is closed, but these microglial cells have already gotten in. The door was open, now they're there, and now they're just causing this low-level inflammation, just smoldering along. Again, this might not show up as a change on MRI, but it's enough to drive some symptoms. This would be sort of a chronic inactive lesion. So with this, the door is closed and there's no ongoing inflammation. I don't know that with standard MRI and the way we're using it right now that we can really tell a difference between these two things. One is giving you some trouble potentially, and the other really isn't. So B cell follicles in the central nervous system, the idea is that these are little nests of B cells that have set up shop in the brain and spinal cord. When we think about our B cell therapies that we use right now in multiple sclerosis, Rituxan, Ocrevus, Kesimpta, Briumvi, these are all really effective therapies in relapsing forms of MS. Ocrevus also FDA approved for primary progressive MS, but there's not good evidence that they can address these little B cell follicles, these little nests of B cells that have set up shop and are causing inflammation in the brain and spinal cord. I wanted to mention a therapy that's on the horizon that might address some of these B cell follicles that are in the central nervous system. So CAR T therapy, CAR, C-A-R, stands for chimeric antigen receptor. The T is for T cell. This research was mostly done and is being done originally in cancer management, but there is a trial now in multiple sclerosis, and there's a thought that this might be a new way of addressing some of these other types of inflammation we see with MS. The idea with the CAR T therapy is that you take T cells from the individual that you're treating, you genetically manipulate them in the laboratory to express this chimeric receptor on their surface, and then you give them back to the person by a blood infusion. With the cancer therapy, you're programming these cells you're putting a receptor on their surface that programs them to go in and kill cancer cells. What they're doing with the multiple sclerosis trial is they're programming them to go in and attack those B cell follicles in the brain and spinal cord. And again, the hope is that maybe these cross the blood-brain barrier and hit inflammation at a whole different level than the therapies that we currently have. So one of the other shifts in the way we think about MS immunology is in the role that we think T cells versus B cells play. A lot of our original research and thought on MS is really focused on the T cells. And the thought was, this MS is a T cell driven disease. And oh, by the way, maybe B cells are doing a little something out there too. Our animal model that we use for multiple sclerosis is called EAE, experimental allergic encephalomyelitis. This is a T cell model of autoimmunity. So as far as we can tell, mammals, humans are probably the only mammal that gets multiple sclerosis. We have not identified, a naturally occurring MS-like illness in other species. We appear to be it. So if we want to study MS in the laboratory and potentially look for new therapies, we have to create an artificial version of multiple sclerosis. And this is done in mice, and it's called EAE, experimental allergic encephalomyelitis. There are two ways we can do that. One is what I call an active induction. So here you're taking myelin basic protein or some other protein from the central nervous system of a cow, putting it with a sort of something to help it sort of amplify an immune response, and you're injecting that into the mouse. The mouse, usually within about 10 days, will make an immune response. It will react to that cow myelin, and in the process of doing that, it will cross-react with its own myelin. And this is really driven by T cells in the mouse. The other way that we can do it is you can take the T cells from this mouse, now kind of represented up here, and you inject those sort of myelin autoreactor T cells into another mouse. And so you're passively giving the second mouse this EAE illness. The challenge is now we know that MS may be much more than just a T cell driven disease. They are working on mouse models that would also be B cell driven. And it's really important that we try to find some kind of animal model that looks more like what we as humans get, because if you're going to do research at the animal level, it'd be ideal to have something that looks closer to real human MS. So old thinking again was that MS really was driven by T cells up here, and that T cells were then kind of recruiting B cells to do a little something also, so that there was a B cell component, but that it was really driven by the T cells. These are macrophages, or what we call, which is Latin for big eaters, and that this T cell response was coordinating this type of damage from the macrophages. Now we know it's probably much more complicated, that B cells themselves can drive what the T cells do, and that there's a feedback loop then to B cells. But the B cells are very, very important. These B cells can make antibodies that are driving some of the damage with MS. These B cells, again, can coordinate what the T cells are doing, and that both of these, both the B cells and the T cells, can help sort of recruit these macrophages or big eaters to cause more damage. I think the more we understand about the complexities of MS immunology, the better we are going to get at treating it. I've compared MS sometimes to the immunology of MS to a never ending onion that has layer upon layer upon layer, that every time we peel back a layer we discover two or three things that we didn't know. And it's both challenging, but every time we understand and discover more of the complexity of the human immune system and MS in particular, I think newer treatment avenues open up for us. So those are some of the updates on kind of the epidemiology and immunology. Immunology is always tough. It sometimes it makes people's eyes glaze over, but I think for those living with MS, for the medical community, I think it's so vital that we understand the immune system, because the more we know about it, again, the better we're going to be at treating MS. And Chris, with that, I will turn it back over to you. We'll throw it open to some questions and go from there.
All right. If you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send questions anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. And our first question comes from Tiffany. Is MS more common in those areas of Europe?
So MS is more common in most of Northern Europe, but again, you've got these little hot pockets, like the islands off of Scotland, the Orkney Islands, where the prevalence is up in the close to the 300 per 100,000 range. To give you some frame of reference, if you look at a high prevalence area in the United States, say Minnesota, you're probably in the 250, maybe 270 per 100,000 range. Somewhere like Georgia, we're probably in the 70 per 100,000 range. Some of these numbers are always shifting as we become a more mobile society, but yes, that it still is certainly more common in areas of Northern Europe. The converse is also true. There are parts of the world where you just don't see it very often. So whereas we do see a lot of MS in African Americans, we don't see as much MS on the continent of Africa. Where you have more European genetics in Africa, like in Northern Africa, maybe somewhere like Morocco, or in South Africa, where you get some Dutch genetics, you will see pockets of MS there.
Our next question comes from Jamie. What do you like seeing, 3T or 1.5T MRI?
So honestly, we'll take whatever MRI we can get, and we can get high quality MRIs on either 1.5T 6T magnets or 3T magnets. And just so people know, so the T in 1.5T and 3T stands for Tesla. That's a measure of the magnetic field. So a higher Tesla magnet, like a 3T magnet, does make better pictures. So we have our two MRI scanners here at Shepherd Center are both 3T magnets. Some communities don't have them, and it's not that you can't get a good scan on a 1.5T magnet. One of the downsides of a 3T magnet is there are medical devices out there. For instance, say the InterSim device or the Axonics device for bladder symptoms. Those have just not been studied enough in a 3T magnet for us to know that they're safe. So for our patients who have those devices, we prefer that they stay in the older 1.5T machines.
All right, our next question comes from Rosie. Rosie, can you hear us? Rosie, are you there?
I'm here. I'm here. You hear me?
Rosie, welcome.
I'm here.
You have a question?
Hi.
Hi there.
Yeah, I wanted to know why is hello?
Hey there.
Yeah, I wanted yes, I wanted to know why is it more women have MS than men?
Yeah. So most autoimmune conditions are more common in women than men. Clearly, the female immune system is a little bit different, and that's probably a double-edged sword. On one hand, women tend to live longer than men do, and that may be in part due to your relatively more active immune system. On the potential downside to that is because of that potentially stronger immune system, women are probably at higher risk for autoimmune conditions. So yes, MS, like most autoimmune conditions, is more common in women. The ratio is probably about 4-to-1, female to male. The exception to that in the MS world would be primary progressive MS. So primary progressive MS is the one form of MS that is more common in men versus women.
Thank you,
Okay.
Rosie.
All right, thank you.
Thank you.
Just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question by raising your hand. To do so, click the raise hand button or press *9 if you are on the phone. I will call on you and then you'll be able to unmute to ask your question. And our next question comes from Anonymous. Will there ever be a cure?
So I think we get that question a lot. And if I were a person living with MS, I would want to know the answer to that as well. I would encourage people, when we think about cure, I would argue that that word cure may mean different things to different people living with MS. So imagine you're a 22-year-old person who's newly diagnosed. You really don't have, you've had a relapse or two, but you really don't have disability from your MS. So cure for that person probably means I want to stop MS dead in its tracks. I would never want to have disability from it in the future. And I would argue for that individual, with current highly effective therapies, we do stop MS in its tracks in a lot of those individuals. That concept is called NEDA, N-E-D-A, or no evidence of disease activity. And that's when you look at studies in MS now, that is a treatment goal for people who are newly diagnosed. At the other end of the spectrum, maybe I'm a person who's been living with MS for a while. I'm maybe in a power wheelchair. I struggle some with activities of daily living. The cure for that person is not only do I want you to prevent future issues, I want you to get rid of my disability now. I want you to repair my brain and spinal cord. So that person, the cure is a little bit different definition. So
Dr. George, sorry to interrupt. Can you stop sharing your screen, please, so we can see your face fully? Thank you.
let me see. There we go. How's that?
Perfect.
Awesome.
Let
So,
me ask, go ahead.
so when we think about the repairing damage in the brain and spinal cord, so that's called neural repair. If we can't repair it, one of the other goals is to reroute. Let's just form new pathways so that we can get around those areas of damage. Right now, we talk about three treatment buckets in MS: treat relapses, treat symptoms, and get on a disease-modifying therapy, prevent future problems. Obviously, we want a fourth bucket, and that is reversing disability. So there is a lot of research going on in that arena. We've not figured it out yet, but I do believe we will figure it out. So that's another definition of cure. I would argue there might be a third definition of cure, and that is, what if we could prevent MS in the very first place? So you're not treating it early, you're preventing it from developing. It has been thought, because of the large role that we think Epstein-Barr virus plays in the risk of MS, it's been thought if you could develop a vaccine to Epstein-Barr virus and prevent human infections, you probably would lower the risk of MS and maybe other autoimmune conditions pretty significantly. So maybe that's another way of thinking about curing MS.
Let me ask a follow-up question to that. It's my understanding that remyelinization is the goal, is the holy grail here. Where are we in sort of relationship to getting there?
So, I mean, there are phase 2 studies. So when we think about the phases of clinical research, there's phase 1, 2, 3, and 4. Phase 3 are the studies that get something FDA approval. Phase 4 is what's done after FDA approval, just kind of fine-tuning things. So there are several, active phase 2 studies looking at myelin repair. A lot of focus has been on mesenchymal stem cells. These are immature cells that have the potential to repair damage in the brain and spinal cord. So there are those trials going on. There are small molecules that are being looked at to repair damage. So we're participating in a study with a compound called IMU, and I think it's 838. Don't hold me to that though. IMU and then 800 something. That is a small molecule taken by mouth that we hope would remyelinate. So there is research going on around the globe, mainly at the phase 2 level. The thing that gives me hope for neural repair also is it's not just an MS issue. So the researchers in spinal cord injury, brain injury, stroke, all of these different neurological arenas all want that as well. Now, some of these areas, maybe it's not myelin repair, maybe it's axonal repair, hooking nerve fibers back up. So there's a lot of work going on, and our answer in MS could help these other arenas. Maybe their research helps our arena. We mentioned neuroplasticity. There is an FDA-approved device that we think specifically addresses plasticity. And again, think of plasticity as, if I have a sort of something blocking that has damaged my myelin and damaged an axon, and I can't get electrical information across that highway, what if I just take a detour around it? So that's plasticity. So from the company Helios, the PONS neural stimulator, PONS neural stimulator, did get FDA approval about a year ago. And we do think that this may help with neuroplasticity. What they showed in studies with the PONS neural stimulator is that people who got aggressive rehabilitation, physical therapy, these were individuals with walking issues. If you took two groups of individuals with MS with walking issues, both got aggressive rehabilitation. One group did not wear the device. One group wore the device during rehabilitation. Both groups got better. The group that wore the device got significantly more improvement. So that device is out there. What it looks like is a headset, but it just hangs around your neck. There's a little wire that comes off of it that ends in a little gold-plated electrode. That electrode sits on top of the tongue, and again, it's only used during aggressive rehabilitation. So we're getting there.
All right, our next question comes from Ben. Can you comment about Frexa? That's Frexa, all caps.
I am not familiar with Frexa. Can the person tell us a little, and I'll Google it here real quick. It may go by another name. That is one that I have not heard of. I tell you what, while that person's maybe responding and I'm looking, let's go to one more question and I will.
Okay, while we are looking for that, our next question comes from, we do have an answer. Frexa la imab.
It looks like, so this looks like it's a Sanofi product. I'm just pulling it up here. And I'm hoping I'm looking at the right one.
Yeah, that's FREXALIMAB.
Yeah, so it's a monoclonal antibody. I'm just seeing if we can find the mechanism of action. So it's early research. So it looks like they published some results in just here and this year. I'm trying to see if we can find the mechanism of action on that drug. So it works through something called CD40. So when we talk about these are receptors on different immune cells. And so like, with the B cell therapies, all of our B cell therapies are anti-CD20 monoclonal antibodies. So this is they've gotten some early results on this product. It looked, frexalimab. And I'm trying to see what they're doing studies on now. So yeah, it looks like they've just published some very early results on it. So probably, where we're seeing is it would probably now go into phase 3 testing if they think these results are positive enough. So it's a monoclonal antibody that's just attacking the immune overactivity through a different route. I would put that into a different camp than neural repair. So it's going to be more in the traditional disease modifying therapy camp. And just so people know, whenever you see, these molecules that end in MAB, like frexalimab, that stands for monoclonal antibody, and the possibilities are just almost limitless. We talked about the complexities of the human immune system and how there are so many different moving parts. Well, anytime you identify a receptor on an immune cell that is involved in one of the steps in the MS process, that is a potential target for one of these monoclonal antibodies.
Our next question comes from Yvonne. Is there a treatment for smoldering inflammation?
So as of right now, we don't think that any of our current disease modifying therapies necessarily attack that level. I would argue that, and we've been preaching this message for a while, that the sooner we can get people on a disease modifying therapy and the more aggressively we can stop the immune process early in the course of MS, the less likely it is, hopefully, that we will see smoldering inflammation. So one of the ways you can think of treating it is by preventing it in the first place. Don't let this whole forest fire kind of get out of control. Let's nip it in the bud. If it's already there, then there is some hope that this class of drugs called BTK inhibitors, which are on the horizon, there are 4 of them in development, and these are oral therapies that address B cell inflammation, but do it through a different pathway than our current B cell therapies. There is hope that those might address smoldering inflammation. We got some not great news in December of 2023. One of those 4 had negative trial results, and that was something called evobrutinib. They were comparing that to teriflunomide or Aubagio, trying to show that their product was superior, and they were not able to show that it was superior. So that was a negative result. A lot more to come on that. So there are 3 others in development. We'll look at the evobrutinib further, but there is hope that those might address smoldering inflammation. And then we mentioned the CAR T therapy, or these genetically engineered T cells. The hope is that those would address smoldering inflammation as well.
Just a reminder to everyone, if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you so choose. You can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on your phone. I will call on you, and then you'll be able to unmute to ask your question. And speaking of, our next question comes from Dylan. In your opinion, does the Octave disease activity blood test provide accurate information?
Yeah, so Octave is a company that has come up with a blood test panel, is serum biomarkers. And so they look at a series of different immune markers. Some of it is something called neurofilament light chain. Others are sort of markers of inflammation. And I do think this is part of the wave of the future. So the hope is that with blood testing, with these biomarkers like the Octave panel, that we might be able to do several things. Maybe it would let us help select the best therapy for the individual. It should let us monitor how your immune system is responding to a given therapy. I personally think one of the areas where the blood test like the Octave panel could be very helpful is in helping to decide when it's okay to stop therapy for a given individual. So what I anticipate that we would be able to do is, let's say that someone's on a given MS therapy, they're 65 years of age, their MS has been stable for years, and we're thinking about stopping therapy. Maybe we do a biomarker panel like the Octave panel, and if there's no evidence of any of these inflammatory markers, that makes us feel better about stopping the therapy. Maybe we stop treatment, assuming the individual feels well, no relapse, no progression, no new MRI lesions. Maybe we redo that blood test panel and see, okay, has anything changed? If it hasn't, it's one more measure of reassurance that yeah, things are really quiet. So I think there are a lot of potential uses for these serum biomarkers like the Octave panel.
All right, our next question comes from Karen. Karen, can you hear us?
Yes, I can. Thank you. How do you know if you have smoldering MS?
Yeah, that's $1 million question. I don't know that we have a way of knowing that right now. So if let's say that you are experiencing PIRA, progression independent of relapse activity. So you see yourself maybe with some symptoms progressing, but you don't have new MRI lesions, you don't have relapses. So that kind of fits the definition of PIRA. I don't know that we know in a given individual how much of that is loss of neural reserve, how much of it might be smoldering inflammation. I think in some people there are other factors at play there too, just general deconditioning. You know, if the person's not very active, if they maybe become sedentary, maybe that's contributing. So I think we still have some work to do on smoldering inflammation. It is, I think, something that it is probably more conceptual right now. We think it happens, but I don't know that we have a great way of measuring it in the clinic yet.
Might it be an MRI when it happens?
So standard MRI, at least and with all of our current measures, is probably not, even with 3T MRI, we don't think that standard MRI is necessarily going to show us smoldering inflammation.
Thank you.
Yeah, it's an interesting, we're sort of living, I mean, I think any time in medical history, we're living through history, but it's an interesting kind of new paradigm in the way we think about MS and inflammation. And I don't think we have all the answers quite yet.
Thank you very much, Karen. Our next question comes from Janice. What is happening with the development of the EBV vaccine?
Yeah, so I know lots of groups are working on Epstein-Barr virus vaccines. It is proving to be a challenge. No one's quite figured it out yet. There are lots of viruses that we've not. They've been around obviously forever and that cause a lot of human suffering that we have not figured out a vaccine yet for. Think of the herpes, common herpes virus. It's human or herpes simplex virus type 1 and 2. So cold sores and general herpes. We've not figured that one out. On a positive side, we do have chickenpox vaccines, both for kids and the shingles vaccines for adults. So we have figured that one out. So it gives me hope that we will, solve that code of figuring out an Epstein-Barr virus vaccine. I wish I could give a timeline on that, but I don't know what that would be.
Our next question comes from Jamie. Have you had patients try glycine or threonine amino acids or alpha lipoic acid?
So there's a lot of interest in amino acids, to do different things in MS. So probably the one that has the best research is alpha lipoic acid. There have been some completed human trials with alpha lipoic acid in MS, suggesting that it could potentially slow progression of disability. I think when we think about risk benefit ratios, I think alpha lipoic acid would be a fairly low risk thing to do. There's less data on other amino acids like the threonine. Again, I don't think there would likely be much of a safety risk there, but I just am not seeing as much completed research on those amino acids. I think the challenge with a lot of the supplements is there's so much data out there, just small amounts of data on a lot of different things. When you think about supplements, when there's data on turmeric, there's data on alpha lipoic acid. Do you take all of those things? And we really don't have a lot of data that says, okay, could there be potential negative interactions? Does one negate the effects of that? I don't think we know that yet. I would encourage people to be as methodical as possible when we're using supplements or prescription drugs. If we can change one variable at a time, it makes it a little bit easier to know, is this doing something positive or negative for me when I try it?
Our next question comes from Rosemary. How is it determined that RRMS has become SPMS?
That's another great question. And when we show these graphs like I threw up earlier that kind of looks at MS over time, it looks like it would be just so obvious that you clearly jump from relapsing remitting MS to secondary progressive MS. And to make things just a little more complex, realize that recently we have divided secondary progressive MS into two different flavors. There's secondary progressive MS with activity and secondary progressive MS without activity. When we say secondary progressive MS with activity, we mean you are still having new lesions on MRI or relapses or both. That's an even more subtle, separating relapsing remitting MS from secondary progressive MS with activity. I would argue that is really getting to a very fine level. To make things a little more complex still, those categories were used to describe the natural history of MS. And so in many people with MS, we are not seeing the natural history of your MS. We're seeing a modified version due to your disease modifying therapy. And I think that does add one more layer of complexity. So maybe a disease modifying therapy stops your relapses and stops your new lesions on MRI, but maybe you're still having a little bit of subtle progression. I think we have to be cautious and humble about using that secondary progressive MS label in that person, because maybe we're putting the lid on your active inflammation. And maybe if we took your therapy away, you'll see the relapses and or new lesions on MRI, and we see, no, you really do still have relapsing remitting MS. The other reason that we're a little bit cautious sometimes about that secondary progressive label, and there's a little hesitancy sometimes to use it, is there is sometimes a fear in the real world that maybe we have put a label on you that is going to make an insurance carrier not want to pay for your disease modifying therapy. Because really these, all of our disease modifying therapies are approved for relapsing forms of MS, with Ocrevus for primary progressive MS being the one exception. So there's a lot of complexity in making that label of relapsing remitting versus secondary progressive. And then there's this, I think, underlying hesitancy sometimes to aggressively use that secondary progressive label. Yeah, that's a complex answer to a good question.
All right, and our last question for the day comes from Anonymous. I have had MS for more than 30 years. When first diagnosed, there were thoughts of mononucleosis being the cause. Any thoughts?
So mononucleosis is one of the symptomatic ways that Epstein-Barr virus can act up. So mono is caused by Epstein-Barr virus. There are some things that look like mono that are caused by another virus called cytomegalovirus, but most cases of mono or mononucleosis that we see in people, and it's usually young people, are caused by Epstein-Barr virus. So go back to those earlier slides when we were talking about how important we think Epstein-Barr virus is. And I would think, that old discussion we used to have about, fear of mono and MS or Epstein-Barr virus, we do believe that Epstein-Barr virus is a very important player in the risk of developing MS.
And that brings us to the end of this event. If you missed any part of this teleconference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for more information. By participating in a short survey sent to you after this webinar, you will help us to learn the type of information most meaningful and helpful to you as the attendees of these conferences. If you'd like to support programs such as these, consider donating at msfocus.org/donate. Be sure to check out our supporter savings program, where you can save more than you give. Be with us next time when our teleconference will be at 6 p.m. Eastern, 6 p.m. Eastern, March 18th, when Pearl Werfel will host Stress and Your Immunity. We want to thank Dr. Thrower, our attendees, and our sponsors, Genentech, Sandoz, Viatris, EMD Serrano, and Sandolfi. We want to wish everyone a great and pleasant evening.
Thank you, everybody.